Very good. Thank you very much. Thank you, Benny, for that lovely presentation. I think I'm about to take the intellectual content of the slides now down about, or the speech is so far down about 10 notches. Anyway, we'll move it. How do I move them forward? Pointer. Oh, this guy. Yeah. Okay. All right. So much for my technology. Right. So we're going to look at what's new in diabetes. Now, if we look at a little bit of them now, there's so much going on. You know, there's only so much we can cover. And I don't want to bamboozle you completely. I'm also going to look at, I think, what's old and having a comeback. I think that's actually quite important. I'm at an age in my life now where perhaps I'm actually looking at stuff that I remember originally, and they're making a phenomenal comeback and going, oh my Lord. Right. So let's start with, how do I point it at to move it forward? Oh, Jesus. Fergal, you're taking the mic now. Am I going backwards? Is that what I'm doing? Okay, sorry. Right, now, I think one of the most interesting things that has happened in the last while is, I'm sure you're quite aware, and you will get a talk into more in the next while about the weight loss agents, the weight loss drugs that have been around for diabetes for, I would say, about 10 years at least. They're around a long time. We've been trucking along with them. We've been using them. They've been advertised to us. We've had reps coming around to us. We've gone to conferences, and it's just ticked along quite nicely. Then all of a sudden, Kim Kardashian gets hold of it, and she goes from this here to that over there within the space of about, I think, about 6 or 8 months. And all of a sudden, I'm been stopped in the corridor 3 or 4 times a day going, can I have some? Can I have some? Can I have some? Can I have some? It's quite phenomenal. I've never seen anything like it. It has gone absolutely viral in the space of no length of time. So what I would say to anyone in the pharma industry is, don't waste your time. There is no point advertising to us. There is no point. There is no point. You need, these kind of influencers seems to be where it's at. It doesn't usually influence my age group, I would have thought. That said, it's quite unbelievable. The S diet, it's being called, and it's all over the internet. I mean, you cannot go online, but you get advertised this stuff. It is semaglutide is the name of the one that she was on. Now, there's a number of them out there, but it is Ozempic or semaglutide that is the one that I get asked for at least 3 times every day. It's called Ozempic, is what its trade name is. Now, I would just be a little bit careful of it, because when you're on the internet, there's been a number of instances of counterfeit semaglutide that's available online. And there's been problems with all kinds of drugs recently going in and out of availability. And this is no different than any of the rest of them. They're actually having huge availability problems. Every California beach babe is on this stuff. So it's actually really hard to get it. As a result, people are resorting to online ways of getting it. And there is some quite very dodgy stuff out there. There's been a case, I know Susanna was talking to me about a case of a lady in Austria who got quite sick taking counterfeit semaglutide and got out and God knows what was in it. But just be careful, that's all I would say. So what it does now, I am not going to go into huge amounts of details, but it is a weight loss injection. It also it will make you lose weight. It controls your blood sugar. Now it's licensed for type 2 diabetes, but no, it's not to say you couldn't use it in type 1, but there's no license for type 1. But it is licensed type 2. It makes you feel fuller faster. That's part of how it works. So your portion size reduced down because you feel fuller faster. It also it crosses the blood-brain barrier quite well, and that's part of your satiety, and your brain satiety makes you feel that bit fuller. It has cardiovascular benefits. It reduces the incidence of cardiovascular disease. There is talk about reducing the incidence of dementia. How you test that without doing a 40-year study, for the life of me, I don't know. But anyway, there is talk about doing that, and it reduces fatty liver. So it does a lot of things. What Kim Kardashian is interested in is clearly one thing. So there's a few different trials on it. In the interest of being a research conference, I'd better present a few of the little trials. The STEP trial is probably one of them, the one that you can see the sequence running through. So the initial trials were done with just pure weight management and in people without diabetes. So you can see here, you can lose about 16.9% of your body weight when you compare semaglutide to placebo. Now, interestingly, placebo will help you lose 2.4% of your body weight, which is interesting. I find with the semaglutide, it's no doubt about it does work. There's absolutely no doubt about it. But when people start losing a little bit of weight, then that's a boot up the backside to start losing more weight. And it brings the whole diet and lifestyle into it. And there's nothing quite as encouraging as actually watching the scales going down. So I think there's a huge placebo effect. That said, you can't dispute versus placebo head to head at 16.9% reduction in body weight. Interestingly, if you go to those with diabetes at the far end of that, at the very far end there, it's only 10.6% in the same group, except that they have diabetes. So there's something about people with type 2 diabetes that makes them lose a little bit less weight than people without type 2 diabetes. And presumably that's, well, partly we don't know, but there are talk about inflammatory markers and all kinds of cytokines and resetting of body weight and all that kind of thing that probably is very influential. So people with type 2 diabetes, it's not purely that they eat too much. There is some metabolic abnormality in those people that they're not losing as much weight as they are people without diabetes. If you add in step 3 there, that middle one, if you add in intensive behavioral therapy, i.e. your diet, your exercise, you can add another 1% to it, short of 1%. Not making me get up my bike at 4 a.m, I have to say, but it does add a little bit to the whole mix. Now, I'm sure the ones in step 1 probably did a little bit of that quite naturally themselves, but it wasn't as intensive as step 2. But it's interesting that it's not as impressive as you would have thought. Over 2 years, it does appear to be sustained. There's no doubt about it. Going up to 104 weeks, that weight loss semaglutide is the lower one. And it diverges very, very early on. So the placebo is the top lighter one. So very, very early on, you find that their weight goes down a little bit, but not a lot. But semaglutide goes down significantly and holds for those 2 years. Because a lot of the issues with weight loss is that it's very, very difficult to sustain it. People can lose weight and you can go on a cabbage soup diet and you will lose weight. There's absolutely no disputing it. It's an intake-output phenomenon. If you're only intaking 500 calories a day, the weight will drop off you. But whether you can sustain that to any appreciable level is another thing. That's where things like Weight Watchers and those kind of programs or Unislim or whatever one you want, they work because they get you habits that you then maintain and habits of a lifetime that maintain that weight loss. But it does certainly, the semaglutide does work up to 2 years. Unfortunately, once you stop it, you see here the semaglutide is that in dark blue line going down. That's the weight loss going down, down, down up to 68 weeks. Then it was stopped. And interestingly, people regained 2/3 of that weight once they went off the semaglutide. So I mean, there's all kinds of reasons for that, but I would have thought a lot of it is what I was just talking about with the Weight Watchers, is those habits. If you don't develop those habits, you don't maintain those habits, and then it just comes back. It just comes back up again. So that's quite disappointing. That it does require that level of you need to stay on it long and short of. Once you come off it, it's going back up again. Now, there is an oral semaglutide. So semaglutide is a once weekly injection, and that's one of the things that puts people off. Now, people who are on insulin don't bat an eyelid. An injection is neither here nor there. But for a lot of people with type 2 diabetes, going on an injection is a big deal. And it is a once weekly injection, so it is an intervention. There is an oral version of it available, and the results are pretty much the same. And now it is coming on the market. It's not available just yet, but the results are much in the same line. We lost 16.9 is what we were talking about before. We're looking at 15.1 here % body weight loss. So it's pretty comparable, same 2.4% placebo, with the side effect profile pretty identical to its subcutaneous competitor version. That's the word I'm looking for. Now, interestingly, where there is it's involved in the system in your stomach. Normally, when you eat, you secrete a little peptide called incretin, and that's normal. We all have that. So when that was identified, they found that what incretin does, it makes you reduce your glucagon secretion, increase your insulin secretion. So they then went after that particular little peptide. And what they do is, when you give somebody semaglutide, it is that peptide. That's what you're giving them. So you're giving them a peptide which increases their satiety and therefore also makes them produce insulin and reduce glucagon. That's how it works. So there are other little receptors on that same pathway. Now, I won't go into the ins and outs of them, but on that same pathway that actually work similarly. And when you put them together, they work synergistically. So the effect is bigger than either one on their own right. So that's what the recent research has been going down that line. And they're glucose-dependent insulogenic polypeptides. They're on the same pathway, but they're just slightly different receptors on that pathway. Now, it was yesterday morning when I was looking at the journal.ie, that very reputed medical journal, with huge peer of value, I'm sure. Nonetheless, it has been licensed. Would you believe? Yesterday morning, they've licensed this new add-on drug. when I go back here, so what it does, it's much the same things, but it just does it synergistically with them. And tirzepatide is what it's called. So it has only just got its license, and it's the FDA license. So it'll take presumably another bit of time to get the European Medicines Association license. It takes again a year or two over and above that, and then it takes us another little bit of time to actually get the thing on the shelves and actually get it into market or into our market. They'll have it in Britain, no doubt, before they have it here. But it's certainly very exciting, and it'll be an injection, and assumedly they'll have the two in the one injection. So I would expect significant weight loss. You're looking at significant weight loss with it. You're actually looking at weight loss in excess of semaglutide alone. So semaglutide in these studies had a 6.7% weight loss, whereas tirzepatide had a minus 13.1. So it's almost double. It is double. It's double what you get with semaglutide. And semaglutide, to be fair to it, is very impressive. So to double it up again is even more impressive. Now, whether there's something coming down the line or something around the corner, I don't know. But the initial stuff, it certainly looks very, very impressive. It doesn't take a huge amount to get through the FDA. I think the EMA would be a lot tighter. They'd be a lot tighter on the cardiovascular outcomes of this. So it could take a little bit of time to hit market, but it's looking like it's coming, and it's coming fast. With the equivalent reductions in HbA1c, et cetera, et cetera. So with the two together, plus intensive calorific restrictions, you're looking at minus 20 to 26% body weight loss. I mean, that's not insignificant. That depends what your body is to start with. That's a damn lot of fat loss. And it is adipose loss. There's some other drugs that we use, like SGLT2 inhibitors, and then and they're very, very good drugs. A lot of what they lose is water, which water does weigh a lot. But this is genuine bona fide adipose loss. It appears to affect lipolysis. It affects cholesterol. All those bad things that you don't want in somebody with type 2 diabetes. All right. Okay. So that's them. And I know there's a talk coming down later in the track on the ins and outs of all of those to a more extent. Insulin pumps, I think you've already heard quite a bit about. Just to give you the basics of an insulin pump, it's just been absolutely game changing for people with type 1 diabetes. If you ask endocrinologists, and they've been surveyed quite a lot, or diabetologists, virtually 90% of them would say that if they had type 1 diabetes, they got an insulin pump. It is a game changer. Now, it's like any little bit of technology. You get out with what you put into it, and there is quite a lot of input required into this. It's like having a little pet. It demands off you, and it demands off you all the time. If you play ball with that, you're going to get huge benefits off it. But you need to be technologically able to do it, have the time, the will, and the input to do it. You can lie to it, and you can make it. You can trick it, same as you can trick anything else, and there are ways and means of doing it. And so it's very much what getting out what you put in. That said, what it does, there's a little box. All the world is about the size of a bleep. Usually you put it on your belt. Now that in itself becomes an issue. For someone like me today, now wearing a dress, I don't have a belt. So you're going to have to find somewhere to stick it. And that can be a little issue in its own right. But it is one that is possible. You can get little straps and stuff to attach it on. It speaks, what you have is a short-acting insulin in the pump, and it dribbles out short-acting insulin all day long. That's what it does. And then when you eat, you tell it how much carbs you're eating. So we need to teach people to count carbs, and you press a little button and it says, okay, and it gives you insulin for what you're eating. And that's the basics of how it works. Now, a step above that is our continuous glucose monitoring that your previous two speakers have been talking about. The sensor, which is attached to your, you can put it on your arm or you can put it on your tummy, that measures your interstitial glucose. It has a tiny little bit of plastic that just goes right under your skin and measures your glucose every 5-10 minutes. And that Bluetooths that information to the pump, and the pump can then decide how much insulin to give you based on the information it's getting from the sensor. Now, you need the sensor to connect with the pump. You need it to Bluetooth, and there are always with technology, we do have issues with it disconnecting and all this kind of stuff. It is another little thing stuck into you on top of all the other things you have stuck into you and on you. But it is very, very good data. It'll only regulate your basal insulin at the moment. It'll only just tick away on that basal insulin. It doesn't have the capacity. It doesn't have eyes. It cannot tell you what you're eating. It doesn't know what you're eating, and it can't deal with that level of carbohydrate intake, but it will come, no doubt. And as far as I know, Google or whoever are developing ways to take photographs of meals, and they tell you what the carbohydrate content. How that works, for the absolute life of me, I can't get my head around. Nor can I get my head around the AI in the pump. I have no concept of how that works, but it blooming does work, and it works really, really well. So the pump speaks to the sensor, and it regulates every minute. It regulates the amount of insulin that you have. So it does work extremely well. We can also pick up all this data. It Bluetooths it also up to some cloud somewhere or other, which can appear on the diabetes nurse's computer over in the diabetes center. So if you ring in with an issue, they can, they have all that data in front of them, and you can discuss it and say, right, well, this is going on, that's going on, whatever's going on. So it's quite, it's technologically way above my head. But it is quite a phenomenal game changer. And from a patient's perspective, it is a game changer. The kind of control you get with this is head and shoulders, to be fair, over what you would otherwise get. That said, it depends on the person operating it hugely. This is the kind of reports we get. And when we were talking earlier on about the target range, so that green box up there on the left-hand corner as you're looking at it, what we get is a percentage in time and range. So what we're looking for is how much time on that pump, the 24/7, Big Brother is watching you. He is watching you. And what's more is he's beaming it back to the nurses in the diabetes center, so they know exactly what's going on. What you're looking for about 70% of the time to be between that 3.9 and 10. That's what you're looking for, about 70% of the time. That's an ideal setting. Now that's hard achieved, to be fair, and there are ups and downs. That's a nicer measure than your HbA1c. Your HbA1c is giving me an average reading, and it's giving me a 3-month rolling average, which in itself was game changing in its time, and it's still a very useful tool. But by definition, if it's an average, you could have a whole load of highs and a whole load of lows, but you know what, your average is going to come in just nice and fine and dandy. But a whole load of highs and a whole load of lows are not where you want to be. So it can be slightly misleading. So your day-to-day is actually really important, and your time and target range is really important for that reason, because it gives you a better feel for it. Now, that said, there's nothing more useless to me than a whole set of data if I don't have the patient in front of me. I can look at this till the cows come home, but if I don't know what you were doing when you had that high, why you had that low, I can't, you need the person sitting there to say, well, actually, I forgot to take my insulin that day, or I went for a run, or I don't know, we had a Chinese. You very much need the patient and the sense of what happened in their life at that point in time before you can go anywhere with it. But this is the kind of printout you get in the bottom. So it goes midnight to midnight. So it'll give you a feel for this patient's sugar was reasonably okay overnight. About 9 a.m. then rose, which presumably was breakfast. So we probably need to have a look at breakfast, either what they're eating or the insulin they're taking. But something's happening at breakfast, peaking at breakfast, it's coming back down again at noon, and it's rising again from presumably evening meal and going down. So for that, we need to just have a look at what's happening at breakfast and what's happening with the evening meal, and have a conversation. Is it the food content? Is it the insulin content? Is it exercise? Is it no exercise? What is happening in there? Is it injection sites now? Because the pumps are subject to that just the same as anything else. You're putting a little thing in under your skin with a little wire to this pump. So you do need to move it around, same as you move anything else around. Right, so they're the kind of reports we get. Now, they are very useful, and there's a lot of information. As opposed to someone who's finger pricking 4 times a day, you're getting information, and it might be fine those 4 times a day. It's just in between, it's up here or it's down there. So it's that in-betweeners. This gives me a lot more information, and gives them a lot more information. And there's also feedback. There's feedback in it. When you do something well, you get rewarded by seeing your target. Now, equally, it goes the other direction. And now, that's your pumps. So for people on pens, you can now get these smart pens. Now, they're not as smart as the pumps, but they're reasonably smart. So the pen has a little device on it that it will record when you took your insulin, how much insulin you take, and it can also Bluetooth that information to your phone to tell you to remind you that, yes, I took my insulin at lunchtime. Did I take my insulin? Did I not take my insulin? It'll all come up on your thing. It'll also come up on the graph, so it'll get an idea of if would have a number of people who were micromanaging their insulin, they're given tons of insulin. They'll see you could give 5 in the space of an hour. That'll all come up on this. It's very useful. I had a lady in clinic the other day, with her mother, and her mother is a lady with the diabetes, and her mother. She's a little bit of Alzheimer's starting, and she lives on her own, but she'll take her insulin, and she'll tell the daughter she's taking her insulin, but sometimes she won't have taken the right insulin or won't have taken any insulin, and tends to make it up as she goes a little bit along. So the daughter's at home then in her own house, worried sick. Can I believe her? Can't I believe her? Is it right? Is it not right? So this is very useful for somebody like that. So when the mom gives her insulin, it comes up on her daughter's phone. Equally, if she doesn't give her insulin, it beeps on her daughter's phone, who then picks up the phone and tells Mom, you gotta take the insulin. And it's the pink pen, it's not the blue pen. So it works very well and gives a sense of safety, I suppose, and it's peace of mind that is worth its weight in gold. So they're very useful, and it's on the phone. Now the only thing about phones is it's tiny. It is very small. As my eyesight deteriorates, I can't see a lot of this stuff. But it is there. It's very, very interesting stuff. Now, coming down the line, there is, well, it's here is stem cell therapy. Oh, no, it's not stem cell therapy is coming down the line. That's not here yet. There's a lot of work going on in embryological stem cells to develop pancreatic islet cells, and pancreas is in their own right for transplantation, etc., etc. It's at the moment wildly experimental. I mean, wildly experimental. It's not something that you or I will be getting in the next possibly 10 years, but it's been there for a while, and it is coming closer. It's coming a lot closer. What's probably coming closer again will be the immunotherapy. Now, we're using this for cancers and for rheumatoids and or loads of rheumatological conditions and gastro conditions. It's now coming, looking at CD3 antibodies, anti-CD3 antibodies for diabetes. Now, it's only a research tool at the moment. There is evidence, certainly in animals, that it will delay the onset of type 1 diabetes. So they're giving it to people early in their diagnosis with diabetes. Now, you need to get it early enough that there are still some pancreatic cells and some beta cells left there. If you're 6 months or a year down the line, a year certainly, you're going to not have enough beta cells to function with. But it's just protective, because it's the T cells, it's the killer T cells that actually damage the pancreas. So what this does is it binds the CD4 antibodies and neutralizes the killer T cells. So they're looking at people with early type 1 diabetes. Now, it's slightly different for diabetes, because people with diabetes, if you have, versus we'll say people with cancer, if you have a cancer and you will take any drug known to man with any side effect and you will tolerate it and you will be happy to tolerate it. If you have diabetes, you're otherwise very well. You're up and about, you're living your life, and you always have insulin. You're not going to tolerate the level of side effects that you will tolerate if you have a cancer. So there's going to be twos and fro's and coming and goings with all of this. But it's certainly coming, and it's very interesting. And I've no doubt it's coming, and it's coming quick, probably quicker than the stem cells are coming. There's also some research going on about giving it, and they think there's a role of enterovirus to actually be as the initial stimulator, the environmental stimulator for type 1 diabetes. So they're looking at giving vaccines to people who are at high risk of type 1 diabetes, i.e. people with family histories of diabetes, giving them virus and giving them enterovirus vaccines. Now, there's some evidence that it is working, but it's very experimental. And unless it's a diabolically simple vaccine to give with no consequences in the wide world, you're going to have to give it to a lot of people, and you're going to have to give it for a long time to actually prove that somebody's not going to get type 1 diabetes. And you need huge numbers to prove that they weren't going to get it, they were not going to get it, or they were going to get it anyway. So it's common, but it's I don't know whether it could die in its feet. We'll see. It's certainly out there, and that's the kind of directions that research is going in. Now, I would say that for all the fancy pants stuff and all the fancy pants technology and all the fancy pants everything, people with diabetes die from heart disease and stroke. That is the God honest truth of what people die from with diabetes. And it is the most disabling thing that people with diabetes will probably ever deal with. So in a clinic, we need to absolutely wholeheartedly not lose heart, not lose the fact that we need to look after blood pressure, we need to look after kidney function, we need to look after lipids, we need to look at exercise. And it's very unsexy to be asking people to exercise and no one listens to you anyway, but it is really, really important. And the fundamentals of that are really, really important. I think it's been interesting in I suppose I've been a diabetologist since 2008, whenever long that is. My practice has changed a lot. More and more the nurses they take on a lot of the day-to-day maneuvering of sugars and the day-to-day maneuvering of drugs, and the role they take. It's just, I mean, for a person with diabetes, they are the be-all and end-all of your healthcare, really. And as they take on more and more of that, I take on more and more of this. And I am much, much more looking at the blood pressure. I'm doing much less maneuvering of sugars. I'm doing much more looking at the whole body and the whole picture. And that's an important transition, I think, because that is the really that's where it's at. That's where the big money is. And often the patients appreciate, they can see the benefits of the nurses improving their glycemic control. They can't quite see the benefits of me putting them on an ACE inhibitor, or and they're thinking, what is your wand doing? Do you know? And they'll attend the nurses' clinics and they won't come to my clinic. It's not quite as easy to see the short-term benefits, but the benefits are there. You just got to bear with it. You've got to bear with it. Okay, that is about all I have to say, Fergal. Okay.
Thanks for what could only be described as a bit of a tour de force. For anyone who knows, Cathy knows that's normally a tour de force. So, any questions from the room? Anna, you're very reliable. We'll just wait for the mic.
Just leave it with you.
Yeah, well, no. I was just wondering, this seems like a daft question, but if they won't come to your clinics to get their ACEs, would you get the nurses to give them their ACEs?
Give the race inhibitors.
Yeah,
We can. You can, certainly can. A lot the nurse prescribing is very difficult. And they're very tight on them, and they're absolutely fabulous. And sometimes they hold them back more than they necessarily by legislation. I personally think more than they have more capabilities than they're allowed to do. The other thing about ACE inhibitors and the whole cardiovascular thing is it's not just one disease in one organ. It's very complicated, and you've got a lot of things playing in. You've got potassiums running here and UNEs running there, and sometimes you need quite a big broad eye, if that's the right word, and they're on it for congestive cardiac failure, or they're on it for this and they're on it for that. It is a little bit more complex than just managing sugars. I mean, that's not fair to say. It's just slightly different than managing sugars. So right now we would tend to do that. Now that will change, no doubt that will change. And I think I shouldn't be criticizing nurse managers, but they hold them very tight and they restrict them. Probably, I'm not sure you could get a lot more out of them, suffice to say, than they're allowed.
so different knowledge baseline and also restrictions.
Different permissions,
Yeah.
I would say, more than knowledge baseline.
Thank you.
I would say.
And you see exactly the same thing with nurse prescribing of x-rays. I mean, doctors can just get a medical degree, have no experience of ordering x-rays, and they're legally entitled to order it on day one, which is crazy stuff. Sorry, there is a question here.
Any thoughts on the implantable GLP-1s?
Yes, and now that would be great when that comes along. What you're looking like a depot. That's basically what you're looking at. Yeah.
It's surprising because you have devices for
Mind
insulin.
Would you mind just repeating the question? The people online won't have
Yeah,
heard.
sure.
or
So
repeat
the question
statement
is
of the
that
question,
any
yeah.
thoughts on the implantables for the GLP-1s? Because it's surprising with insulin you have continuous delivery devices, but for some reason the FDA rejects for the GLP-1s. Yeah.
It will come. There's no doubt
Yeah.
about it. And they've sent them back with a few modifications, but they're not big modifications.
Yeah.
I think it will come, and I think it's coming soon. And be very interesting when it does.
Yeah.
But I think, to be honest with you, I think GLP-1s will be very, very quickly. It'll be GLP, GIP together. I think that's probably where it's going. So from a pharmacological perspective, I'm not sure how much they'll actually progress GLP on its own. I think it's now taking a step towards the two together.
Yeah.
I think that's where it's going. So I think they might need to go back to the drawing board with that, but it's definitely coming. There's no doubt about it. And the longer acting ones, because when I started out was Byetta, which is a once daily injection. Not that makes a whole lot of difference, but now the once weekly makes it. We use the once weekly an awful lot as well, aside from the weight loss for elderly people at home. That the public health nurse will go in once a week and give it, and it's very, very handy. Besides having them injecting insulin every day, particularly people who are living on their own, will say, or there's social difficulties. So if it was implantable, even better.
I have a quick question about the Ozempic drug for control the weight. And one of the side effects that I read about that is the thyroid dysregulation. You can get like some cancer as well in the thyroid. The new drugs that they are testing, are they seeing something in this line as well, or?
Well, not currently. And the GLP-1s, when they came out first, there was talk of them. There was pancreatitis risks and there was the risks of thyroid cancer, but actually it's never really stood up to stringent testing. And for it'll be very interesting to see what the next, I'd say, 5 to 10 years brings, when we have just huge volumes of people, huge volumes of otherwise well people on it. I think it'll be very, very interesting to see what happens. I think that's my phone actually. Ben, my phone's on the floor. It's just reminding me the grand rounds are normally on at 12:55. Sorry. I just need to shut it off. Thank you, James. You better not snooze.
Two questions, maybe. Given that pretty much every child with type 1 diabetes is now on a pump, I mean, do you foresee the day when every type 1 diabetic will be on a pump?
No, I don't. I think it's very much personal choice. I have a number of people who don't want to go on because it's constantly attached to you. It's that there's a discretion with just having a pen. There's a control over that. I think people are very, very different, and I think I from my point of view, I love pumps, but it's not for me. I'm not living it, and it's not for me to impose it on somebody else. It's very much it's very personal, and I have some people who go on a pump and don't like a pump. So I think computing for different people and different. I think there'll always be a room for it. I think there will. I think that's where the smart pens should be really good, actually.
And my second question then, given what you said about the STEP trial and the subsequent trial, which showed that the weight loss effect on type 2 diabetics was less than on the general population, is there any evidence for type 1 diabetics, one way or the other?
That the weight loss, no, they haven't given, there's very, very few trials in GLP-1s in type 1 diabetics. And they're a very under-researched population, and I'm not sure why. Because they're sitting ducks for this, and they would accept an injection faster than the average bear. So I don't know why it's so restricted. From a weight point of view, we do certainly use them, but no, there's no, to the best of my knowledge, there's nothing, no.
Okay, any final questions? Since we're ahead of time, and Cathy didn't
Go on.
screw that up. That's been a fascinating presentation. Well, that was only the pressure just to make sure. Because, you know, there's one person standing between us and lunch now. So, any final question from the room? Okay, can I thank Cathy again?
Thank
for
you.
passing?